Hey everybody, it's Dr. Jaime, and the Fit and Fabulous podcast is a safe space for all kinds of discussion, and today's sponsor is USSWSH. They're all about self-love, a wellness brand that's changing the conversation around self-pleasure. USSWSH's self-love movement is all about empowering people to love their bodies and the amazing things that it can do by breaking the stigma around self-pleasure. After all, self-pleasure is the next big thing in beauty. You guys just watch. It's great for your health, it's great for your skin, and it's great for your mood. I'd love to introduce to you the favorite vibrator from USSWSH called the Empress 2. The Empress 2 is a vacuum clitoral stimulator. It's ergonomic. It has a cute pink design. It's got curves that fit all the right places. It's got powerful vacuum technology. It's 100% waterproof. Perfect for bubble bath time. There's 40 pleasure combinations, something that works for every body. Magnet, USB charging, there's no fussing around with batteries. It's discreet in all the ways. Your business stays your business with a quiet design and discreet shipping. So you guys, embrace self-love by adding the Empress 2 to your cart right now. You can use the code FITFAB, that's FITFAB, for an exclusive 60% discount on the Empress 2. And please visit the link in the episode notes right now, where you'll also find the discount code. Thank you to today's sponsor, USSWSH. Welcome to the Fit and Fabulous podcast with Dr. Jaime Semen. Hello, everybody. It's Dr. Jaime, and welcome back to the Fit and Fabulous podcast. I'm super happy to have you here, and thank you to everybody that has been listening to our episodes, downloading them, sharing them, commenting. You guys are helping spread all these super important messages all over the entire world. Well, I'm super honored to have today's guest on the Fit and Fabulous podcast. Her name is Dr. Rachel Rubin. She is a board-certified urologist and sexual medicine specialist. She's only a handful of physicians in this entire country, you guys, that's fellowship trained in sexual medicine for all genders. That means both men and women. Dr. Rubin is a clinician, a researcher. She's a passionate educator. I found her on social media. In addition to being the education chair for the International Society for the Study of Women's Sexual Health, she serves as associate editor for the Journal of Sexual Medicine as well. Dr. Rubin completed her medical education at Tufts University, her urology training at Georgetown University, and her sexual medicine fellowship with Dr. Irwin Goldstein in San Diego. Dr. Rubin, welcome to the Fit and Fabulous podcast.
Oh my goodness, it is my honor. And thank you so much for having me. How exciting. I've been following along on your social media, and it's just incredible what you're doing and how many people you're reaching.
You know, it's interesting when I got into this space, of course, everybody, my followers know I'm a huge fan of nutrition and exercise, but I'm an obstetrician and gynecologist. And so it's amazing to me the lack of good education out there when it comes to sexual health and sexual medicine. So I love what you're doing and pioneering kind of in that space for women. So I just want to applaud you for that. And so tell people a little bit about yourself and how you ever started pursuing sexual medicine. Everybody has a story as to why they are where they are now.
Everybody has a story. It's so funny. When I was in my medical school training, you sort of get to pick your schedule and decide kind of what order you do things. I said, oh, well, maybe I'll like surgery. Maybe I'll like OBGYN. I really like, some women's health topics. So I picked surgery early and I picked OBGYN early, and I loved surgery. I loved the operating room. And OBGYN, I loved the surgical parts of it, the gyne oncology, the GYN surgeries. And then I went into the delivery room and nearly passed out late one night while a woman was screaming. And I said, oh my God, this is not for me. I didn't love the labor and delivery side of things. And so urology was, was such a wonderful place where I could take care of all genders and really deal with women's health issues and with quality of life issues. And I love that. And sexual medicine was fascinating because I found when my training is that my attendings, my doctors above me who were training me were terrible at talking about sexual health issues, just awful. And I was not shy about those conversations. I wanted to have those conversations. I love asking people, getting into people's business and just letting them feel open and able to answer questions. And so I naturally sort of found this field. And then I found, the fellowship, which is the only fellowship in the country that really even acknowledges women's sexual health, which is wild when you think about it. We have about 27 fellowships in men's sexual health and only one that really focuses on, both, all genders. And that's got to change. And so that's kind of my story. It's not too sexy, but I gravitated towards what I loved and what I was good at talking about. In medicine, you want to do, the thing that when you wake up every day, you're like, yes, I get to go to work. This is awesome. And I totally found that.
Awesome. That is so incredible. So let's start talking about what you actually do as a practicing clinician. I'm thinking that people are thinking that you're like just a sex therapist or, there's lots of different people that work in this space. So let's start with men first. What are the common conditions that you treat men for?
Yeah, absolutely. So, I think it's really important when we're dealing with sexual health issues. I am not a sex therapist, but we always look at people in the context of what I like to call biopsychosocial. So I have to really understand your biology, your history, everything you've been through. Do you have diabetes and high blood pressure? Have you had surgery in the pelvis? Have you had cancer? I really need to have a high level of understanding of the biology to really understand what plumbing is working and not working, and how do we optimize it to get it to work better. And so that's the biology piece. But I can't do it in 10 minutes. I have to actually get to know my patients and figure out what kind of sex are they having? What kind of sex do they want to be having? Who are their partner or partners, or what kind of partners do they want to have? How do they grow up? What are their barriers? What are their, I sort of leave it to the end in terms of what is their cultural, religious, or trauma related things that they think are related, because it sometimes is relevant, but often it is not relevant. And really for men, when they come in, it's kind of all the same actually for all genders. We deal with really 4 buckets of things. It's arousal problems. So for men, erection problems; for women, arousal or engorgement problems. Orgasm problems, libido problems, and issues surrounding pain. And you can really put it in those buckets for all genders. And then really, it's funny, I spend a lot of time thinking about how men and women are really similar, and their anatomy is really similar, and their physiology is really similar. Whereas I feel like the world loves to tell us how different we are. But I think as a urologist, I have a unique ability to really understand my female patients sort of in a way that we sort of understand our male patients. And so most people think it just should be an OBGYN's job, but I'm here to argue we deal with genitals too.
Yeah, absolutely. Okay. So I'm sure the first thing that comes to mind for a lot of people is erectile dysfunction. How common is this in men? What should they be talking to their doctor about?
So it's super common, and actually you really are important in this conversation as an OBGYN because you do so much education on health and wellness and fitness. And that's really important. If you are a young man with erectile dysfunction or erectile problems or erectile dissatisfaction, you don't have to call it dysfunction, but if your penis is not working the way you want it to be, it may be a medical problem that you need to see a doctor for. So if you think about it, everyone knows what a heart attack is, right? So your heart, you get a blood clot in your heart and your heart stops beating. And so if you're clogging your heart, right, those arteries are pretty large, and your penis arteries are really small. So I can give you numbers, like the heart arteries are about 3 millimeters. The penis arteries are about 1 millimeter. So for many men, erectile dysfunction comes long before your heart attack. So we always say that like what's good for your heart is good for your penis, but really erection problems can be a marker for future cardiovascular issues or heart issues. And so it is, it used to be a young guy comes in with erectile dysfunction and he sort of just, the doctor rolls their eyes at him and says, go to a sex therapist. I'm finding that the sex therapists are sending these patients to me, and I'm finding real cardiovascular risk factors and really bad family history of cholesterol, family history of heart attacks, and I get them to cardiology really quickly. And so your penis can be a marker of, whoa, I really do need to start taking my health seriously. I need to start exercising and eating right, getting my cholesterol down, and potentially seeing a specialist, to make sure I'm optimizing my health. So erectile problems are very common. If you're 20, there's about a 20% chance. If you're 50, there's about a 50% chance. I saw a guy in clinic just on Wednesday, and he was 75, and all of a sudden, his erections worked until about a couple of years ago. He said, "Doc, I'm the only one of all my friends who has this problem." I said, "Nuh-uh, 75% of all of your friends have this problem. They're just lying to you, and they're not talking about it because they want to make you feel bad."
Yeah. Yeah. It's something that a lot of patients, like women, female patients in particular, if you don't ask very specific questions about their sexual function, their libido, their arousal, they're not likely to just give up that information. And I think for men, right, we think of them more as sexual creatures than women, that they're just walking around with this like constant spontaneous desire and multiple erections per day. But it is a problem that I think a lot of people are afraid to ask about.
And they're also, they're afraid to ask about it. And they're also really afraid to talk about it with their partners. And it actually can feel really personal, right? Your partner, oh, honey, can you not get an erection because I'm not pretty anymore? Or you're not attracted to me, or you're cheating on me, or you're watching porn. Most of the time, the answer is actually high blood pressure, diabetes, stress, no sleep, all of those things. So there's actually, in men, we love to talk about the biology, and in women, we love to talk about the psychosocial issues. And unfortunately, we have to start talking about all of them for everybody.
What's their chance of clinical improvement with just lifestyle intervention?
So it's high in the sense of if your diabetes is out of control, getting your diabetes under better control, things will get better. Just like you have, everyone checks the bottoms of your feet for numbness. The nerves to the penis can be affected as well. So I do like to tell my patients, right, getting your A1C better. If we can get you off blood pressure medications, if you need blood pressure medications, you got to take blood pressure medications. But if we can get you off blood pressure medications, then your erection issues are going to get better, because many medications have side effects. And so if you have very high blood pressure, that's going to worsen your erections. But also if you're on some of the medications, that can also worsen the erection. So you can work with a sexual medicine specialist sort of to make sure your medications are optimized, but also that you're working on those lifestyle issues, because absolutely you can see improvements. There's not a ton of data, but there is data on Mediterranean diet. Different diets have been looked at, but that's the one that sort of has the most data around it.
Yeah. Yeah. And just like you said earlier, if your cardiovascular system is functioning optimally, then your sex organs should be too. So, what would be common medications that people wouldn't think of that are well known to cause sexual side effects?
There's lots of them. So antidepressants can often cause sexual side effects, but it's kind of a double-edged sword. If you are depressed and cannot get out of bed and you're truly clinically have, issues, then you're not going to have good sexual function either. But some of them, not all antidepressants, but some of them can have, properties that can either raise problems with libido, orgasm, and arousal problems. So, and that's
for both men and women.
Both, all genders. Yeah.
Yeah.
Yeah. And sometimes it's just switching around which medication. Sometimes it's adding a certain medication that can counteract that. And so you really, again, it's getting a doctor to really know you, care about you, and really want to work with you to tinker. It's not a one size. I wish it were a one size fits all, but you have to have someone who's willing to take the time to tinker. And the problem is everyone expects their one doctor to solve all their issues. And it turns out it has to be a team approach. You have to look at this from multiple lenses and get people to really sort of take you seriously and talk to you about what's going on. So I would say antidepressants is a very common one. Certain blood pressure medications like metoprolol, which is really common, can have a high incidence of erectile problems. And so really there's tons of medications that can have sexual side effects. That doesn't mean don't take any medications ever. That just means, understanding it, then you can kind of figure out what to do about it. Do we add? Do we subtract? Do we change things around?
Right. What role do medicines like Viagra, Cialis play? I mean, do they work for everybody, or who are good candidates for those types of therapies?
They work pretty darn well. So I love to, it's all about education, educating people how they work. And so when you think, oh my gosh, Dr. Rubin, I'm taking my man pill, I'm taking the thing, I don't like that I have to take this pill to get my erections. Well, when you break it down to say, what does it do, right? Your penis is a muscle, it's smooth muscle, like your bladder, your bowels. So it's smooth muscle. When that muscle is relaxed, it fills with blood like a sponge. It expands, it gets bigger, 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 and it gets big and hard. So when that muscle is stressed or in fight or flight mode, or there's a tiger chasing you, or you're stressed, or you haven't slept, or your muscles aren't healthy, then you squeeze all the blood out of it and you lose the erection. And so all Viagra and Cialis are are muscle relaxers. They relax smooth muscle. And so if you can get that muscle to relax, then the tissue will expand and get bigger. But it has to get to the muscle. The muscle has to be healthy. The nerves have to be functioning in order to get the muscles to relax. So I always say you need, in order to have a healthy functioning erection, you need healthy muscles, healthy nerves, and healthy blood flow. And any kind of many medical conditions can affect all of those. Surgeries can affect the nerve, can cause nerve damage. Low testosterone can cause muscle dysfunction. And so it's really understanding, okay, you come in with erectile dysfunction, but part of it is understanding, well, why do you have this? Can we get to some underlying issues? Can we fix all of it? No. Let's try pills. If pills don't work, we've got injections. If those don't work, we have a toolbox, which is not as large as I would want it to be, but certainly much larger than I have a toolbox for my female patients, to really give guys the tools to just have better and more fun sex. And I think that's the issue too, is changing mindsets to say, what is the goal of sex right now, right? Is it fun? Is it procreation? Is it a competition? Like, what is the purpose? And also, can we change your mindset about what gives you joy and pleasure? Because it's not the same for everybody.
Yeah, I think the psychological component is underplayed too. I clinically, I treat only female patients, but sometimes when we're doing a workup for infertility, I will find that a patient will say, well, actually, my husband is having some issues. He's having erectile dysfunction because he's had sex most of his life just for pleasure. And now they're really actually trying to get pregnant and he's all up in his head. Or I've had the exact same situation where we're trying to do a semen analysis and they simply cannot ejaculate just due to the psychological component of just feeling under pressure.
Totally.
Yeah.
I see a ton of infertility patients on both sides. Sex is too painful. I can't, my pelvic floor, my vulva, it hurts to have penetration, help us, Dr. Rubin. And I see the erectile issues or the orgasm issues on the other side. And so that's when we get creative and we really try to dissect out what are the issues. If you have people who have sex once a year and then all of a sudden, and they're happy with that, they're fine. It's not bothersome, but now they want a baby, how do they go from having sex once a year to having sex every other day for the 5 days around ovulation? It's not easy. It's actually really challenging. And it takes away all the intimacy, all the fun, all the spontaneity. And so sometimes I take the stress out of it and they leave my office with a urine specimen cup and a 5cc syringe. And I say, here you go. This costs $0. Ejaculate into a cup, draw up the sperm from the syringe and just put it in the vagina every other day for 5 days around the time of ovulation. And when you want to have spontaneous fun sex, do it, right? And just taking away this pressure of you have to do it this way in order to procreate. Obviously, that's the inexpensive way of doing, fertility treatments because not everyone can afford IUI or IVF or something like that. But we're in DC where people are very busy, they travel a lot, and they have a lot of money. And so they don't necessarily even have time to have sex, to have a baby. So we have very busy fertility clinics that have just people who are too busy to have sex every other day for 5 days. And so he goes in and gives his sperm and she gets her, IUI or IVF from there. So there's lots of reasons people do fertility treatments that aren't just sort of what you think of as infertility.
Gosh, and that's sad. I don't know. It made me sad inside to hear you say that. But it is. I mean, these are real problems in our society and the way that we
it's sad. It's sad, but I think the other thing is who are we to judge what happens in other people's bedrooms? And I think too often people have too many people in their bedrooms with them, right? It's not just them and their partner or partners, but it is their middle school gym teacher who taught them sex ed. It's their, clergy members. It's their parents. It's their grandparents. It's their friend, their football buddies who are judged. Everyone has these people who they bring in with them of who they think are watching and judging them. But most people are not live casting their sexual, adventures, on the internet. And so who cares? Get them out of the room, have whatever makes sense for you and your partner, or just you, right? everyone deserves pleasure, intimacy, love, and connection, even if it's with yourself, even if it's with a partner. And so doing more, how do we optimize that and have more of that and less of the guilt and the shame? You do not have to look like a supermodel to have love, connection, intimacy, and, and you don't need that. And I think too often, well, if I can't have the erection that I had when I was 19, I can't even have an orgasm. I don't deserve an orgasm. Well, that doesn't make any sense. You're wasting a lot of pleasure, right? You're wasting your time. So I think 2022 or 2021 and 2022 is really helpful to say every day we wake up and we're living is a blessing. And, how do we just enjoy ourselves and have fun?
Have you seen any data on COVID and erectile dysfunction?
Yeah, there's quite a bit coming out, especially COVID, especially unvaccinated COVID cases. We're seeing a lot more blood clots and things that are clotting. And so people get blood clots in their lungs. Remember, the arteries to your lungs are much bigger than the arteries to your penis. So if you're getting these clots, it can affect erections, and it does affect erections. So we actually have a big social media campaign out there about really encouraging people to get vaccinated because of the effects of COVID on erectile function. And the rates are quite high, actually, in the few studies that are coming out.
Yeah, interesting. Okay, so let's segue into women, because more of my followers are women. And I did have Kelly Casperson on my podcast. She's so phenomenal.
She's a good friend. Yes,
yeah,
everyone follow Dr.
So
Casperson.
Great. But even some of the bread and butter things, I want to hit them again because people need to hear this. What is genitourinary syndrome of menopause?
Yes, my favorite topic to talk about. So if anyone follows me on social media, will always hear me talk about GSM, or genitourinary syndrome of menopause. And it's a huge problem. So anyone in menopause, so for most people that's over age 50, although it can happen earlier, and you don't have to not have periods to have this happen to you. So the vulva and the vagina, the bladder and the urethra need hormones to be healthy. They need hormones to be healthy. If you want to get a picture in your mind of what are genitals without hormones, think of a baby's vulva. It is raw, it is irritated, it is red, and they pee in their diaper all of the time because they have no control. Then babies get hormones in their body. That's called puberty. And those baby girls become teenagers who are very not nice to their mothers, as I've noticed. But their bodies change. They literally morph. You develop labia minora. You get an opening that is pink, that is healthy, that lubricates, that can become sexually active. And your bladder and your urethra and all of that also become healthy. And so what happens in menopause is exactly the reverse, right? You lose all the hormones. And so all of that tissue, it gets thin, it gets raw, the muscles start to get thin and atrophy. The acidity, you lose the acidity. So the vagina is supposed to be very acidic, right? The stomach's supposed to be very acidic. The vagina is supposed to be very acidic so it can fight infection. And so you lose the acidity of the vagina. And so bacteria can grow and the microbiome really changes. And so you develop a risk of urinary tract infections, and not just urinary tract infections, but urinary frequency, urinary urgency, leakage can increase. And sex can become painful because the tissue is so dry, it's so irritated, it's so thin. And so it happens to almost everybody over the age of 50. For some people, the symptoms start to get really bad at their 60s. For some people in their 70s. I've got 90-year-old patients who come in with issues, and it's all genitourinary syndrome of menopause. And the treatment is so easy. It's so safe. It's so effective. And it's literally something that should be used like a seatbelt, like sunscreen, like face moisturizer. It should be used by every woman over 50. It should be over the counter. It's not dangerous at all. If you've had cancer, then we just need to talk to your oncologist. But even the data there's no data showing risk in cancer patients. And it's a local hormone therapy. And you can either do local estrogen therapy or local DHEA therapy. And that doesn't go in your bloodstream. It doesn't cause blood clots or dementia or cancer. And you have to keep using it. Just like you can't put your seatbelt on one time and you're safe. You have to put it on every time you get in the car. The vaginal hormone therapy has to be done. Typically, it's a twice a week therapy. And it usually takes, again, the tissue is so thin and irritated that it takes about 2 months to get strong again. And so the problem is somebody comes into your OBGYN office, you see them for 10, 15 minutes, you tell them they need this prescription, they take it home with them, they don't really remember why, they don't really understand it, they try it for a month and they say, oh, it didn't work, now they throw it in the garbage, where it's going to take 2 months to work and it will not keep working unless you keep using it. And so that's a long-winded answer of it's really important.
I mean, I'm with you 100% of women. There's really, so breast cancer patients, I just want to reiterate that still a candidate for vaginal estrogen therapy, even if you had an ER positive cancer, work with your oncologist. I find most oncologists are really gun shy about the whole issue and will just say, no, use vaginal lubricants and moisturizers, but, I will print off the data for patients so that we can have, discussions about this because it really affects their quality of life. I mean, you talk about saving a woman from breast cancer and now she's having horrible sex that affects her relationship. I mean, the words that women have used, my vagina feels like sandpaper. I mean, it's a huge deal. The other complaint I have is insurance coverage for vaginal estrogen therapy. That's a huge barrier sometimes in my practice.
So there's tricks, and I love tricks. So most insurance companies will cover something. So it's figuring out what they will cover and also the cash price. So you can get a generic vaginal estradiol tablet, 10 micrograms for about $40 a month using GoodRx coupons and cash coupons. And so the key is knowing the tricks and getting your staff to help you, like be really forceful in getting women to understand. And we have to work on my social media. I do a lot of yelling for the advocacy part of this because we have to get insurance companies to understand. We have to get the box labeling changed because, it says there are all these dangerous things about it, which there are not. And so we have a lot of work to do. And what I would say is part of it is we have to take it away from it being, I'm a sexual medicine doctor. I love talking about sex, but I actually think in this case, sex makes everyone uncomfortable, and sex in women over 50 makes people really uncomfortable, which is ridiculous. But we have to make it about urinary health. So instead of Mrs. Jones, you need this because it's going to fix your sex problems, it's Mrs. Jones, you need this because you have urinary frequency and urgency, and you've got 3 UTIs this year that could get you into the hospital with antibiotic resistance. I don't want to give you any more antibiotics, because ultimately you're going to get sick. You could get in the hospital, you could get urosepsis and die. This is why you need your vaginal estrogen therapy or your vaginal hormone therapy. And so I think it's really important to get it that people think, oh, it's about sex, I shouldn't complain about that, or I don't need a treatment, or I don't need to spend $40 a month for my sex life. It's no, you need to spend this because you don't want to end up in the hospital with urinary tract infection. I think that's really the mindset shift that we need as providers, that this isn't about sexual health. This is about genitourinary health.
Yeah, I still find that there's a lot of women that I feel like I'm trying to talk them into it. Can you talk, just for our listeners, the difference between systemic hormone replacement therapy and vaginal estrogen therapy?
Yeah, super, love talking about this. So if I were to draw your blood or my blood right now, right? Depending on where I am in my cycle, my estrogen levels are going to be somewhere around 50 to like probably 150, right? When I was pregnant with my kid, my estrogen probably was as high as 3,000. I mean, you know better than I do, probably, right? It gets pretty high. I'm a urologist, though, but it gets, like 3,000. If I draw my mother's estrogen levels right now, right, they're going to be zero.
Right.
Okay. If I give her vaginal estrogen, her estrogen levels in her bloodstream are still going to be 0. Now, my dad, if I draw his blood right now, or my husband's blood, his estrogen is about 25. Okay. So I like to just I say, oh, well, my dad has more estrogen than my mom does. That doesn't seem fair. So my dad's bones are protected. His brain is protected. His, heart is protected. So it's a little bit frustrating, actually, that women are supposed to have an estrogen of 0, over 50. So that's systemic hormones. If I give vaginal estrogen to a woman, her estrogen stays 0. It stays in that menopausal range. It doesn't go through your bloodstream. So if it doesn't go through your bloodstream, how is it going to cause a stroke, heart attack, blood clots, breast cancer? It doesn't. And there is no data to prove that it does. And so that's the difference. Now, there are many women over 50 who we do give estrogen for their whole body, women who have hot flashes, night sweats, osteoporosis. And so there are many reasons why we do give hormones for the whole body. And I tend to, use FDA approved, more a biosimilar or bioidentical, it's like sort of a marketing difference, but there are a lot of FDA approved products, that put estradiol in a patch or in a gel or in a ring, to give you estrogen for your whole body. But for a 99-year-old woman who comes in with urinary frequency, urgency, and urinary tract infections, vaginal, local vaginal hormone therapy is safe, it's effective, and it won't cause any harm.
Absolutely. And there's lots of ways to dose it. There's creams, there's gels, there's capsules, there's tablets, there's rings that you can place in the vagina. So there's a slew of options. You a lot of times have to figure out, what does your insurance cover, like Dr. Rubin said, and sometimes our new EMRs are kind of nice because we're starting to get more of that information, where even a year or two ago, you'd have to send the prescription. They'd have to go to the pharmacy to see. Some of those barriers are becoming less and less. And like Dr. Rubin said, there's prescription savings programs. There's some compoundeds I find are cheaper than actual prescriptions. So you just have to find a provider that's willing to sometimes jump through a few hoops for you, but it's dang worth it.
It's very frustrating, right? I can get a man Viagra or Cialis for, $12 using cash coupons, and I cannot get my female patients, vaginal estrogen. It's the same problem, right? It's literally, what is the point of us giving all of this erectile function medications when, partners don't.
Who are they having sex with? Yeah. And then I just wanted to touch too, in case anybody was confused. So estrogen gets made from aromatization from testosterone. So the reason her dad has an estradiol level of 25 and her mom is 0 is because the ovaries are done making estrogen, not too much testosterone. And then men have such a, 10 to 30 times the testosterone that women do. They do have kind of a similar decline andropause that happens as they age, but they still convert a lot of their testosterone into estrogen. And so that's why they're able to maintain some of those levels. Okay, so let's move to the vulva. So for people that don't understand, the vulva is the outer portion, the labia and the clitoral hood and things like that, where the vagina is actually more of an internal organ, or it is. Let's talk about things that itch on the vulva. I think that's a common thing women will come in for, and it can be so many different things.
Yeah, I think I had a popular Instagram post that just said, not everything that itches is yeast. Thank you for coming to my TED Talk. I think it's really important that everyone understands that itch is a sensation. It's an awful sensation, actually. It feels terrible if you're itchy and you cannot find the source of the itch. But at its core, it's sort of a neurological thing, is that feeling of itch. It's a feeling. And so you have to see someone who will look and really understand, where is this itch coming from? Is there a skin problem? Does it look red? Does it look puffy? Does it culture for yeast? Then maybe, it's a yeast infection, which can commonly happen. Other things that can cause itching, there are skin conditions like psoriasis, like lichen sclerosis, like lichen planus. There are, Behçet's. There are so many dermatological, lots of, your vulva is just skin. And so anything that can happen, eczema, right? We see tons of people with eczema of the vulva, which has a fancy name called lichen simplex chronicus. And it's horrible, right? It's this thick, puffy itching. You see scratches all over because women stay up all night scratching. They have to wear gloves and Benadryl, and it's really an awful condition. And so so many dermatological things can cause itching. And then neurological things can cause itching. So for all you Peloton enthusiasts out there, I'm going to just tell you, sometimes it is your Peloton that is causing your itching, your bike riding, and what happens is the nerves to your vulva are from the nerves that come through your hips, called the pudendal nerves. Pudendal in Latin means shame. So just to give you a sense of how deep all this vulvar shame and genital shame goes, is the Latin word for the nerve to your vulva and the nerve to your penis is called the pudendal nerve. And when you sit on that bicycle seat, you are crushing your pudendal nerve, which means you can get erectile dysfunction. You can get arousal problems and clitoral problems and itching of the vulva, because of that nerve damage that can happen. Now, I'm not saying, listen, bicycle riding is very good for your heart health, and I'm not saying don't exercise, but if you're someone who's having more pelvic pain, it's really and you're like, I keep getting yeast infections, It may not be a yeast infection, actually. It may be nerve damage from that pudendal nerve. And so we love working with people called pelvic floor physical therapists. They're the greatest humans on earth because they understand how the spine, how the hips, how the lower back, how the pelvis all work together and really help us get out of some of those itch crises and pain crises.
Yeah, absolutely. Absolutely. Okay. So, yeah, that's a good one because most patients will call, I have a yeast infection, and just
And
want
in
treated.
the time of COVID is you just give them the prescription, you don't examine them, and I'm not blaming them. It's the time, it's a really challenging problem right now, but that exam can really help say, this really isn't a yeast infection. It's genitourinary syndrome of menopause, or it's vestibulodynia, or it's, a nerve issue. And I think that physical exam is really underused in this situation to really say, like, what is actually going on? Where is it itchy? Can I figure out where the itch is coming from? In a lot of ways, where it doesn't itch is just as important as where it does itch, because that can really help us. If it's all right-sided, you say, well, I don't think a yeast infection really would be all right-sided, or, oh, I don't think your religious upbringing is causing you to only have pain in this one area when you have sex, right? There's something else going on.
Yeah, such an important thing. Such an important thing. Okay, let's segue into another really common disorder that I see in my practice, hypoactive sexual desire disorder. What is it? And what can we do about it?
Absolutely. So HSDD, hypoactive sexual desire disorder, is low libido. Basically, you have low interest in sex. Now, you have to be bothered by it. So if you say, well, I'm not interested and I don't really care, it doesn't bother me, it bothers my partner, but it doesn't bother me, not a medical problem. I'm not bothered. It's not, you have to be bothered. You have to come to me and say, geez, Dr. Rubin, I used to want, and I don't want anymore. And I really want to want. I liked that flicker. I liked when I got interested. I liked when my partner initiated and I got excited, right? It can be spontaneous desire of like, oh, I want to, engage in sexual activity, either with myself or with a partner, or it can be responsive desire, meaning, oh, I saw this sexy movie and now all of a sudden I want to go upstairs and, have an orgasm. Like, so for many, many people, that light switch goes off. They used to have it and they no longer have it. And so we look at HSDD, or low libido, in a biopsychosocial framework. And I think the media and the research really loves to push the psychosocial, which is great. I love the psychosocial. How do we get your brain more excited? Your brain is a huge sex organ. How do we boost dopamine? How do we get you more interested? How do we set you up to succeed? And a lot of it's education. How do we get you to understand that you deserve pleasure, but what gives you pleasure is maybe not what gives your partner pleasure, and your pleasure is just important as your partner's. That's all wonderful. But my argument is there's a lot of biology that goes into it. And I saw someone post on social media recently that said, when you're a teenager and you can't keep your hands off your partner, nobody's going around saying, man, they have a deep emotional connection. They have great communication, right? Nobody says that, right? They're hormonal, right? They're hormonal. They can't keep their hands off of each other.
They just met like 10 minutes ago.
What's that?
They just met 10 minutes ago.
Right. They don't have any deep emotional communication. No, right? And yet when it comes to adults engaging in activities, it's all about the deep connection. And they went, no, it's hormonal too, right? We just don't really like to talk about that. We don't like to talk about the dopamine surge. We don't like to talk, but there is a biological basis and component that goes with libido. So if we can all agree that, and I just said earlier in this podcast, that antidepressants can lead to sexual problems, right? So if I can give you a pill that's going to mess up your libido, well, couldn't I give you a pill that might boost your libido? Absolutely, I can. And there is available FDA-approved products that can boost libido. And so I think too often we tell women, oh, it's totally psychosocial. It's totally just about your environment and your communication. And yes, that is true. That is a lot of it. But there is also tools that we can use to boost dopamine in people's brains to get them having more interest, more thoughts, more fantasies. And people don't like when I say things like that, because they think, drug companies are just out to tell women that they need to have sex a certain way. It's just not true. I mean, I think these medicines have been studied, they work, and they work not in everybody, but no medicine works in everybody.
Yeah, absolutely. And, Kelly and I, Dr. Casperson, we really talked about how men are so much more they have so much more spontaneous desire. Women have a lot more reactive, and I tell women that sometimes you need arousal first. And that is just a total misconception. People think that there's something pathologic with them if they don't just have spontaneous desire all day, every day. And in a normal menstruating women, we see this testosterone surge around ovulation. Sometimes that's normal to only want to have intercourse, a few days out of the month. Sometimes it's not every day. But one thing I do find clinically, Dr. Rubin, is that, and we know that this orgasm gap persists just across, all countries and ages and things like that. But I think that even within monogamous relationships, there tends to be an orgasm gap. Why is that?
I always say that we can fix the pay gap if we fix the orgasm gap. So, listen, I think, like you said earlier, that men we think of as sexual beings, they deserve sex, they need orgasm, they need pleasure, they deserve this carnal, physical touch. But women don't. Women don't need that. Women only have responsive desire. Women are not sexual beings. We love to play into these stereotypes that women, don't deserve pleasure the same way that men deserve pleasure. And I think it's how we raise, right? We talk to young boys about, you're 13. Oh, we got to talk to our son about masturbation. We got to talk to him about. We don't have those conversations about women. We talk about foreskin hygiene in young men. We don't talk about clitoral hygiene in women. We teach women from a very early age. We teach young girls that you have to be a good girl. You can't be a sexual being. You can't do this. So the question is, what is nature and what is nurture? And how much of this is, well, we don't talk about it. And so then you go and you have a relationship. You say, oh, well, my partner, he needs sex. And we're speaking very heteronormatively at right now, but my partner needs sex. My partner needs an orgasm a day. Okay, well, I don't need it. So let me just give him an orgasm. Let me just have him have pleasure. And it gives me pleasure to please my partner. Well, women don't often think, well, I should get pleasure. How about I have an orgasm and he doesn't? How about I have 3 orgasms and he doesn't? Women can have multiple orgasms. Men typically are one and done. They have long refractory periods. So where the ratio should be 3-to-1, right? A woman should have 3 orgasms to every 1 male orgasms. And it's the opposite. So for every, for every 100 orgasms, a heterosexual woman has 66 orgasms, right? And so it's this, I don't know whether it's because we're caretakers and we're supposed to take care of everybody else before we take care of ourselves, but there is an inherent feeling that women do not deserve pleasure the same way a man does. And I think it's a lot of society telling us that and us believing it, as opposed to that carnal biological nature.
Yeah, I cannot agree more. And I think that what I see with patients in my clinic too is that when I say, is your sexual function normal? How are your sexual relationships? That they are answering that question based on how often they're having penetrative intercourse. I think that when I say, if I were to say, how's your sex life? They would answer something like, well, I'm having it twice a month or once a week or whatever it is. But I want women to hear too that you might not be in a relationship and you don't necessarily need a partner to have orgasms. And I talk about this really openly on my social media, and I know it makes people skin crawl. I don't know how my own mother feels about listening to it, but I talk about masturbation a lot. And I have 3 daughters, so it's a super important subject for me. I'm reading this amazing book right now, Your Daughter's Bedroom. I don't know if you're familiar with the book. It's such a great book, and it talks about your relationship with your own mother, how that sets a lot of kind of what we, perceive to be normal or abnormal or dirty or icky or whatever it is about our own bodies. And I find that even grown women sometimes don't know their own anatomy. They don't know what their vulva looks like. They don't even know where their clitoris is. If they don't, their partner sure doesn't. If you don't know what touches feel good to you, how could you ever communicate that to a partner?
Totally. Right. And you go to the doctor's office and we have a sheet that we're like mechanics and we're hiding under the sheet looking at your vulva. You just said the vulva is the external part of the body. You get a mirror out, and as the women should be watching their exam every time they go to a gynecologist, you should be looking and watching from the pediatrics on, because these are private parts to us, right? We instill in women that these are private, sensitive areas that you should be ashamed of. And that starts early in pediatrics. pediatrics. Instead of, if your arm breaks, you go to the doctor, you say, look at my arm, right? If your vulva breaks, you need to say, look at this tissue and let's see what's going on. And so we instill this, doctors instill it, parents instill it, this idea that these are private parts. And then you have a partner and all of a sudden you're supposed to be a sexual goddess who's so comfortable with everything. And your partner now is supposed to know every button and every way to touch you that feels good, even though you don't know yourself. And so it comes down to education. It comes down to, empowerment and getting people to understand that, like, I spend so much time in my clinic just explaining anatomy, right? I showed, everyone gets a mirror in my office, and I showed a 70-something-year-old woman, and she emailed me later that day. She said, I never saw my clitoris before. That was the most empowering, incredible exam I ever had, right? She's 70. She's not too old to learn something new. I teach my male patients about the female body. I bring in partners to show them how their partner's vulva is hurting and why it's not all in their heads. And I show them, look, here, it hurts here. Again, it's educating people through anatomy and really getting them to understand what's going on, but it's a huge problem.
Yeah, it's incredible as a gynecologist to just observe, as you were talking about, showing them the mirror, even in childbirth. When I'm delivering a baby, sometimes I'll ask a patient, would you like a mirror? Would you like to see? And some patients are totally adverse, like, oh my God, no, I would never look at that. Or they don't want their partner to see. And it's like, you guys got into this situation somehow.
For some people, that's the first time they're ever looking, and there is a child's head coming out of it. I can imagine that would be very traumatic, because it's not something we encourage women to look at and to see and to really understand that this is part of your body. The clitoris is part of your body. You can see it. You can pull the hood back and see the head. Sometimes that hood gets stuck and it can cause pain or decrease sensation. But, gynecologists don't routinely examine that part of the body. We don't routinely teach the vulva exam in med school, which is crazy, right? The clitoris is never examined routinely by anyone. That's crazy. Can you imagine me saying, as a urologist, I don't examine a man's penis because I don't want to make him feel uncomfortable? Mm-hmm. What? No. Why isn't the clitoral exam a routine part of every pelvic exam that you do, right? We can find pathology. There is pathology that exists within the clitoris, but we don't even talk about it. So how many women are going around there saying, I can't orgasm. It hurts when someone touches my clitoris. I don't find pleasure in this. And it's not because of their religious upbringing. It's not because of their trauma. It's because they have clitoral adhesions, right? Or they have smegma built up under there.
Yeah, absolutely. Okay, ladies. You heard it, Dr. Rubin, Dr. Seaman. We want you to get a mirror and look at your own vulva and learn your own anatomy. And once you feel comfortable with it, then teach your partner something. I mean, it's
you should have been a urologist, Dr. Seaman.
That's what everybody says. Actually, I have a really funny joke about that, but okay, I'll just say it. So I was actually I was a med student at the time. I was pregnant with my first daughter, super pregnant, like 9 months pregnant. And was on my OBGYN rotation, and a urology resident came up and I got introduced, and he said, Dr. Seaman, you should have been a urologist. And I was like, yeah, no, I don't really do penises. And he was like, clearly you do. So the inappropriate things that sometimes people let come out.
You would always get away with that back then. These days, I don't know that you'd get away with it, but as urology residents, we have the best jokes and the best sense of humor. So
yeah.
I always joke that I would have changed my last name if my husband had a better last name. If I could be Dr. Seaman as a urologist, I totally would have changed my name.
You have to be able to laugh about it. Okay. So, another topic that probably doesn't get talked about a lot, we're talking about people not having enough orgasms, people not having enough sex, but persistent genital arousal. Tell people what that is and how common it is or uncommon it is.
You did your homework, girl. Man, we're getting through a lot of issues today. So persistent genital arousal disorder, or PGAD, and has newly been, the name is evolving. We also add something called GPD, or genitopelvic dysesthesia. It's sort of a nicer term for a PGAD, or persistent genital arousal disorder. And this is a condition that happens in all genders where, and it's different for everybody, but you feel For many people, they feel on the verge of orgasm all the time, or this constant genital awareness or buzzing, or basically you feel you're in a car and you feel on the verge of orgasm. It's not sexual at all. It's not wanted. It's not something, it's not a hypersexual state, but your body is in a hypersexual state. You feel aroused all the time. You feel on the verge of orgasm. Some patients are orgasming constantly. Some orgasm helps them feel better for a minute. Some it makes them feel worse. The suicide rates are actually pretty high. It's a horrible condition. And it's been very under-researched and under-looked at, and unfortunately these patients go to doctors and the doctors make stupid comments and say, oh, I wish my wife had that, or, oh, this is a great, and these, it's just an awful condition. And there's a big paper published very recently by ISSWSH, the International Society for the Study of Women's Sexual Health, about how to properly diagnose and treat these patients and what we know to date. And really what we're finding is that there is some sort of neurological misconnection going on. So just like we all understand sciatica is leg pain, okay, right? If you have sciatica, you've got leg pain, but the problem is not with your leg, it's with your back. And so you can put all the creams and gels and surgeries on your leg, but it's not going to fix the sciatica problem because it's a back problem. And so PGAD, it seems to be often it's not a genital problem. Sometimes it is, but it's not usually a genital problem. It's actually usually a nerve problem. And that nerve problem can be anywhere from your brain down to the genitals themselves. And so really it could be a problem with your clitoris. It could be a problem with that pudendal nerve. It could be a problem in your back, like sciatica. So instead of shooting pain down your leg, it's arousal sensations in your penis or in your clitoris. It can be a brain problem, like you take a certain medication and the part of your brain that senses or feels arousal or controls arousal is overactive. And so what's so incredible about the disease is it really was a group of patients that all came together on Facebook and said, we all have this problem, we need answers. And through their advocacy work, they basically were able to get a group of providers together, and that included spine surgeons and neurophysiologists and sexual medicine doctors and mental health people and physical therapists. And they all got in a room together, and over 2 years were able to sort of pare down and really solve some big issues that have been happening in this condition. It's not perfect. We still have a long way to go, and these patients are really challenging to treat. But if you go to a spine surgeon and say, I've got PGAD, you're going to get laughed out of their office. They're not going to know what to do with you. And so we have a lot more work to do.
Yeah, it's such a small sector that deals with that. But I wanted to talk about it because there may be somebody listening that knows somebody or they themselves have this disorder. So just know that there's experts out there that can help you. So of course, because I have to be able to laugh at my last name, the last segment of all my podcasts is called the semen analysis. And you actually said something about this when we were talking about the orgasm gap, which is the pay gap. So there is some really interesting research, and actually I pulled the most recent data that came out from 2020, but while women actually outnumber men as OBGYNs, so the profession that I work in used to be very much a male dominated field, women on average make significantly less money. And the pay gap extends even into subspecialties where people have gone on to be fellowship trained in things like reproductive, endocrinology and infertility. And so this study was published in Fertility and Sterility, but it showed that even when you adjust for variables like worked hours, years in practice, location, academic versus private practice, these specialists make significantly less than their male counterparts. And the 2020 data, Doximity publishes this every single year, this online social network of healthcare professionals. Women doctors make 27.7% less than male physicians, which equates to about $116,000. And there was a recent commentary in the OBGYN journal that noted that 82% of those going into OBGYN were women, yet the field is the fourth worst of the 18 specialties when it comes to pay inequity amongst the sexes. And it's not just OBGYN, of course, I'm highlighting that because that's the field that I work in, and urology is really not that far off when you look at the data. And there's huge gaps in things like orthopedic surgery, ENT, geriatrics, people who are in research. What's the deal with this, Dr. Rubin? What are your thoughts about it?
Well, we have a lot of work to do. I mean, I think the field of OBGYN in general is so rooted in misogyny that it's unbelievable, right? I have patients who are so angry with their OBGYNs. Why couldn't they fix my sexual problem? Why couldn't they fix my pelvic pain? And I actually say to them, I say, wait a minute. So here you've got a doctor who spends more than half their time delivering babies, in the emergency room, dealing with really emergent issues, going to the operating room to deal with life and death issues like torsions and cancers and things like that. And they're supposed to be your experts in sexual medicine and take care of every issue that women have ever.
And we're primary care.
What doctor for men does all of these things? Because I'm a urologist and I'm expected to know some things about the penis, the bladder, and the prostate. That's it. They have heart problems, they go to their heart doctor. If they have headaches, they go to the neurologist. The idea of what we think OBGYN should be able to do is just rooted in pure misogyny, that women are not deserving of entire whole healthcare, and that you're supposed to do it in a 10-minute visit once a year. Give me a frickin' break, people. And so research money is not going to women's health conditions. It's not going, to endometriosis and to fibroids and to adenomyosis and to pelvic pain. And we hate women so deeply that we can't even get out of our own way, because it's so rooted in who we are as a society and as a culture. And so I don't even know the solution, because it is so problematic. We make up 50% of the gosh darn population, and we can't even see it. We're so blinded to these inequities. And so it's hard to get out of bed in the morning. Sometimes it's hard to advocate for yourself, and it's hard to live in this world where you try to advocate and you say, and they're just not going to hand it out. And so I think it's going to take women working together, supporting each other, because historically women do not support each other. And we think that there's only one seat at the table. And so I think really, really working together and bringing people up and supporting each other and finding those colleagues who are supportive of you. I have many male colleagues who are the reason that their support of me is the reason I'm here today. And so really finding ways to work collaboratively and not so competitively, because medicine is a very competitive place. And so I don't have an answer. I just know I'm as sickened by it as you are. And the solutions, it turns out, is not often to complain and yell and scream and demand equality, because it turns out that doesn't seem to really work either.
Yeah, I mean, I echo a lot of things you're saying. I'm the personality type. I mean, I don't complain. I show up and do my job and work, but I completely agree with you that the arrows that have been shot at me in my career probably came from more women than men, honestly. And so I think sometimes as women, we need to figure out how to get out of our own way. And I don't have the answers and solutions either, but Dr. Rubin is a mom too. She's got kids just like I do. And I just applaud you for what you do and being a pioneer in your space and having kids and still taking care of yourself. People don't get the recognition for the amazing, incredible work that you're truly doing, Dr. Rubin. So I just want to say that.
Thank you so much. It's such an honor to be here and for giving me this platform. You have such a huge following and are doing such great work to get people to take care of their bodies and to work hard. And sex is similar. You have to work hard at it. You have to work hard at making it fun and making it better. If it is worth it to you, then it's worth the hard work. And sometimes that's adding technology and fun devices. And sometimes that's adding sex therapy to learn how to communicate with your partner. I truly believe no one is so good at sex that they can't get better. Everyone can get better at sex. And so if it's important to you, then work at it. If it's not important to you and you're not bothered by it, it's okay. And it's really just understand that if you are bothered by it, there are people who really care about this. You can go to ISSWSH, ISSWSH.org. There's a find a provider, and any provider on there will be educated at least to be able to say, this is real. What you have is real. Let's work together to find a solution, and you'll be in really good hands.
Incredible. Dr. Rubin, tell people how to find you if they want to connect with you.
Absolutely. You can find me at rachelrubinmd.com. You can find me on any social media. Well, you can find me on Facebook, Instagram, and Twitter. I have not been brave enough to go on TikTok yet, at Dr. Rachel Rubin, and would love to connect with you. I'm still learning different social media strategies, and maybe you can teach me more.
Yeah. Well, I don't know. I'm just paddling. Just keep paddling. You guys go follow Dr. Rachel Rubin. I love the content she puts out about sexual medicine and topics that we totally need to be discussing more. So thank you guys so much for listening to the Fit and Fabulous podcast. Share this with all your friends, men and women. Have a great day, you guys.